gentlemen, welcome to the Cameroon Town Hall for Healthcare Professionals, our second edition for the year 2025. And as you would have all noticed, we have moved from our bi-monthly sessions to now monthly, once a month. So henceforth, the Cameroon Town Hall for Healthcare Professionals will be holding just once every month. For the past 3 years or 4 years, we've been able to sustain, holding these sessions every 2 weeks. And we have achieved quite a lot without ever missing a session. We thought it is wise to give ourselves some time to better prepare and get the right speakers. So we go now once a month. If you are joining for the first time, this is a Cameroon Town Hall for the healthcare professionals. We meet on this platform to discuss on health issues that affect our country, Cameroon, and we bring in experts from across the board in all the fields, clinical research, public health, all the different specialties. We've had all the kinds of amazing experts from Cameroon and other countries that have been guest speakers. We so far have a total of around 2,600 members, or those who have attended at least one session of the Cameroon Town Hall from across 36 countries now. So we keep growing our numbers and growing our global reach on the Cameroon Town Hall for Healthcare Professionals. So thank you for attending this session. I'll be co-moderating the session with Dr. Brian Tegomo. Hello, Dr. Brian.
Yeah, hi Elvis. It's great to be back. I haven't been around in a while, so really great to meet you all. It's really been a pleasure. I think we're living in really interesting times, and I'm really thrilled that we've decided to talk about these issues. I think a lot has changed since we last we last spoke. So I both in global health, in just digital technology, and how those resources are being used. So I thought it'd be a really fantastic idea to maybe channel and discuss some of those challenges, and particularly how it's going to affect us in Cameroon. So I'm thrilled about the topic. I think it should be probably one of the most important discussions that we can have. But I hope that at the end of this dialogue, we will come up with something that could be helpful, impactful, and useful for our country and also for the continent. Over.
Thank you very much, Brian. Quite a very interesting topic, very timely. Global health at Crossroads. So I think there'll be a lot to share on this platform today. I want to hand over to our chair, the chair of the Cameroon Town Hall for Healthcare Professionals, Dr. Muno Ken, whose leadership has been amazing over the past 4 years, making sure we all get the right speakers and make sure we sustain this initiative up to now. Hello, Dr. Muno, welcome.
Yeah, thank you, Elvis, and thank you, Brian. Thank you for everyone who takes up time to attend the town hall. Yeah, I think this, as you both eloquently express, is one of those things that we need to get to a point and reflect about the importance of aid. So, as we all know, the USAID was created in 1961 by J.F. Kennedy, and his goal was for the US to be a force of good, meaning it was a foreign policy that was geared not just towards fighting wars, but doing soft power. And a lot of people may not know that the US alone is responsible for almost about 40 to 50% of all aid. There's a difference between aid, which is borrowed to you, and people call it aid, which China and the others give aid, is loan, which is different from helping and trying to empower nations in terms of healthcare, also trying to empower them and trying to help women develop. This organization's history and efficiency has been put into question today. Multiple other organizations that we'll talk about, but no one looks at soft power. America has exerted a lot of soft power, even in areas where they are hated. Majority of the help that we have going on in Gaza is provided by the US. Majority of the help in Africa, all the programs, the major programs, are being supported by the US with different programs and different philanthropic organizations, almost 90%. The question we have here is, what's next? There is a whole geopolitical war going on in terms of, even in the US, how much power does the president have? That's not our discussion today. And how much power does the judges have, and who can stop what and get things going? So I think it's also a cry for Africa in particular. We've been crying for the past decade for Africa to fund its healthcare system. Few African countries have actually met regulations for them to be able to provide at least 15% of their GDP on health. Is this the time? So there's a lot to discuss, Elvis. There's really a lot to talk about. Today, we did not find a specific speaker. We thought it wise that we have a lot of public health members here, and also others who are interested in health policy, and those who are affected. So over to you, Elvis. I'm really excited about this topic.
No, really excited, Mona. Thanks a lot. And as you would know, as of the fiscal year 2023, the United States Agency for International Development, known as USAID, managed over $40 billion in appropriations, representing more than 1/3 of the funds provided in the Department of State Foreign Operations. And the recent action by the U.S. administration to dismantle this organization has led to significant disruptions in global aid programs. You know, the withdrawal of U.S. aid funds had led to severe consequences for vulnerable populations worldwide. For example, in South Sudan, the suspension of aid has resulted in food shortages and closure of health facilities, exacerbating the malnutrition and suffering that is already going on in this country. You know, the impact extends to numerous countries, not just Cameroon, where essential services such as education, healthcare, agriculture have been halted. In Afghanistan, for example, schools have closed. In Gaza, where there were some more critical supplies, all have stopped. And in Haiti, agricultural aid has also ceased. So all these disruptions endanger the well-being and stability of vulnerable populations, forcing partner countries to bear, unexpected costs, or, what they call abandoned sustainable development goals. So the dismantling of USAID also poses risks to international security and U.S. interests as well, because programs related to governance, stability, that also threaten the U.S. National security interests are all at stake. So I think the withdrawal creates a void that may be filled by other autocratic donors like China, Russia, the Gulf states, who could broaden their influence and generate a new kind of dependency. So I think in summary, we can think that the withdrawal of the U.S. aid funds adversely affect vulnerable populations dependent on its program. So it's time for us to look at it through the lens of global health alone. And that's why we are here today. And we'll be expecting us to really just have a frank talk among ourselves and share to know how this withdrawal of U.S. aid funds affects global health. And I would want to pass it over to the co-moderator, Brian, to share some of the perspectives and an intro to this topic before we open it up for discussion.
Yeah, thanks a lot, Elvis. I think we are still grappling and recovering from the lingering effects of COVID-19 and the disruptions that it caused. I think in Africa, we are still grappling with the challenges, with the rise in chronic diseases, and our surveillance systems are not really adapted to handle those either in terms from a surveillance perspective. Climate change, as you know, is also rising, Elvis, and we are still trying to figure out how that's the disruption is causing in terms of our food chains. Other things that are happening, we spoke about AI towards the end of last year, and the impact that it's had. Last year, just about a year ago, where AI was and digital technology is significantly different from where it is today. So I think a lot has happened since we last spoke. We are significantly, I think, underprepared from every angle. We are seeing new administration in the United States and the impact that the U.S. withdrawal from the World Health Organization and other countries following suit like Argentina and Italy and others. and that the impact that this will have on global health is concerning. We've been talking about USAID, but the ramifications extends beyond that. You know, it's affecting the PMI program, it's affecting maternal and child health, it's affecting the TB control programs, PEPFAR, obviously, and I think a lot of others. But I hope that we kind of put this in a whole nutshell. It's like a bubble that's hitting us all, which I think we are significantly underprepared for. But I really hope that let's have some dialogue. I think the big issue here, Elvis, is for our countries to take ownership of this problem, political ownership of this problem, and really run with it. I saw the letter that was written by a minister of health last week. I don't know. Yeah, earlier this week. I don't know if someone has a copy of it that they can share in the chat. But essentially saying that this disruption is not going to affect us. This is how we are going to scale in order to take care of malaria and all the other programs that he listed in his letter. So I think this is a wake-up call, and I hope we can have some honest, controversial discussions about this. Irrespective of what aisle of the political spectrum you are on, I think no one should disagree that we need to take ownership of our own problems and try to resolve our own challenges. There is a saying that, there's a book that I read called Toxic Charities, that the more aid you give to a country, it kind of establishes dependency among those. So I think we are sort of in that brink, and I hope that, I really hope, Elvis, that we can have some engaging discussion. So the way I wanted us to talk about this is, first of all, to expose what the challenges are. I want to hear people's perspective on what they've heard, how they see the recent the foreign aid change, U.S. foreign aid policy changes, how that's potentially going to affect us, what they see as the beginning of this. How can us in Cameroon or in Africa be better position to deal with this thing? So I sort of wanted us to maybe have or frame this in that particular context, and maybe take it from there. I don't know if you have other thoughts, Elvis, on how we should
No, absolutely, Dr. Brian, you're right. That's exactly the purpose for which we choose this topic for today, to allow that kind of a broad-based conversation on how we can look at the impact of this suspension, but look at it through the ways in which we can make some contributions or recommendations on how countries can tackle these problems internally. We have one of our co-moderators, Dr. Kate, who has just joined us. Also, I'll be passing it on to Dr. Kate. But Brian, just to continue to take some of the areas in which we want to talk about the impact of this suspension. The recent suspension of the funding has significant implication also for HIV care in Cameroon. The U.S. aid has been instrumental in supporting Cameroon's HIV response, particularly through the President's Emergency Plan for AIDS Relief, PEPFAR. This support encompasses community-based prevention and treatment services with focus to vulnerable groups such as orphans, at-risk, and children. So the funding freeze has led to immediate disruption of HIV services across countries in Africa, including Cameroon. Reports indicate that some HIV clinics are closing due to stop work orders issued by the U.S. State Department, halting essential services for people living with HIV even before Michael Rubio actually said they could permit some of the essential services to continue. In Cameroon, U.S. aid's contribution has been really pivotal in providing antiretroviral treatment. People might not know that most of the free antiretroviral medications that HIV patients take in Cameroon are bought through the U.S. Taxpayers' money. So the withdrawal of these funds really jeopardized these services, with potentially leading to disruptions or interruptions in or maybe increased transmission rates. So we are actually going back to a lot of gains that had been made in the fight against HIV. So I think that suspension threatens a lot of this progress that has been made in universal health coverage in Cameroon. So I think we want to look at the different sectors in which this withdrawal of US aid funds has affected our country. And I'm just trying to paint some of those areas that you can actually see the impact is palpable. At this point, I'll pass over to another co-moderator, Dr. Kate. Dr. Kate, welcome to this session, and would like to get some of your introductory remarks.
My point. Yeah, thank you, Elvis. Really, we are in really I would not say, I don't want to say perilous times. I hope these things don't stay for long. Hopefully I hope it's just a suspension and not the end of most of what we've been talking about and what Brian was mentioning. On the flip side of that, I think Brian talked about this political ownership. I'm just coming from a meeting in Denmark as well, where we were looking at type 1 diabetes care in Cameroon and in many other sub-Saharan African countries or low and middle income countries. And it's virtually the same thing because type 1 diabetes care depends solely from donations from many international agencies. And it's a particular disease where, if not treated, the person with the disease dies for lack of insulin. So almost, the same picture. And the huge part of the discussions in that meeting was around sustainability of these programs and for governments to take ownership, because we are not going to rely solely on external aid. So I really just look forward to what we are going to discuss and the insights that we can bring on the table or into the discussions, and how these can be channeled, back to the Ministry of Health for the next steps. Thank you very much.
Thank you very much, Dr. Kate. You're taking it through the lens of diabetes and other non-communicable disease. So we are all just broadening the scope of the impact of this suspension. And when we now talk about how can countries take ownership, it first of all starts from the very beginning. How much of state budget is dedicated to healthcare? I think if we go back to the Maputo Protocol, if I'm right, it actually specified that countries should dedicate 15% of their budget towards healthcare. I think as of now in Cameroon, in the recent budget that was voted in Parliament, I don't know if someone can correct me, the budget that is allocated for the Ministry of Public Health is not up to 5% compared to the total national budget. So really also showing the commitment that countries have to make towards taking care of their own public health system. So let's look at it through some of the problems that you all have identified as far as the suspension is concerned. So I'll open it for discussion. Please, if you want to speak, just indicate with a show of the hand, and let's start the first conversation by assessing the impact of the suspension. We want to hear your thoughts about it before we move towards what can we do? What can we do as a country? And I know we have Professor Theodore Gacho, who is here from the United Kingdom, and is an entrepreneur in healthcare sector in Cameroon. Dr. Theodore, if you are an operator in the private sector where people take ownership of their healthcare by paying out of pocket directly in Cameroon, and they come to you, do their HIV test, pay from their pocket, and those who come to your clinic pay for their services. How do you see this suspension affecting the private care sector? In the healthcare sector in Cameroon, the private health sector?
Thanks very much, Elvis. It's good evening here, and I'm sure it's good afternoon or good morning elsewhere. I think the question is quite an interesting one. So many people in Cameroon, we know that in Cameroon, over 70% of the health spend is out of pocket. So I'm very surprised that people are actually very concerned about the suspension of US aid to Cameroon. Yes, there are lots of programs that will stop. But I think if you can actually pay 70% out of pocket, maybe the minister is right that the government or the Cameroon people can find a way to meet up with the remaining 30%. The weaker part of the population will suffer, as always. The weaker part of the population will suffer. I think this, as most people will say, is a wake-up call for many developing countries that they need to actually do their own things and make it work for them and not rely on aid. Aid is supposed to help you establish is not supposed to run your projects. I read somewhere that USAID has been running for over 60 years. And if USAID has been running for over 60 years in Cameroon, and we're still depending on the aid, then we have a problem. And I think we need to go back and find where is that problem and address it. Now, talking about people coming to my center, unfortunately, I think those who come to my center will probably still come because they don't rely on this USAID. I really, truly, I'm sorry for those who cannot afford it and rely on the aid. But I think as a people, we need to go back to the drawing board. We've been having aid for over 60 years, and we have not done anything better with it. I think we need to review that.
Great. Now, thank you very much, Professor Ngacho, for your thoughts around how that affects the private sector. We agree also that those who are suffering from HIV and on antiretroviral drug do not depend on the private sector for their antiretroviral drug. Most of them depend on on the free distribution of antiretroviral drug, which is part of the USAID package. And I agree with you that if this has been done for a long time, we should have found a way to have a strategy in place to take ownership of buying this vital medication for our HIV patients. We have one of our co-moderators from Canada. I think Dr. Matt Sandrine is here with us. Hello, Sandrine, and Happy New Year.
Hi, Elvis. I'm pleased to be here. Unfortunately, I cannot go on camera, but I like the discussion today. Hello, everyone. Hello, Professor Ngacho. I like what you said about the fact that 70% of the cost of medical care in Cameroon is actually paid out of pocket. And I just want to mention that foreign aid is not only aid provided by international agencies, but when we think about foreign aid, we can also think about aid provided by families overseas, outside of Cameroon. And I believe the World Bank has estimated that this aid itself has actually, it's more than what we receive from international agencies. So during COVID, I don't remember the numbers, but I remember that that's where we saw a soar in the aid that came from people from the diaspora to their families in Cameroon. And most of that aid went for to cover medical costs. So this time around, I think we will see probably a surge also in remittances sent to our countries to help fill the gaps. So I just throw this idea out there. Maybe this is a time where we can think about a coordinated effort from the diaspora, because I'm assuming most people here are from the diaspora, and I apologize for the noise in the background. But I think this is something we can think about. How can we channel what we've seen during COVID, because this is the time. Foreign aids not coming from people back home. I mean, people who have left the country. It's always going to be dependent on the willingness of the donor to continue that aid. But if you are someone from the country and you have moved somewhere else, you're still attached. So it's very difficult for you to cut off that aid just like that. So that's just a food for thought for everyone. How can we channel those remittances and build a sustainable system back home? Thank you.
Thank you very much, Sandrine. I like your approach. USAID funding has been cut, but our remittances home has not stopped. So let's continue to send money back home and continue to pay for the medical bills of our families that deeply rely on most of the remittances that we send home for them to access healthcare. That's very true. Thank you very much. We also have our own Dr. Fobi, who is here with us. My radar spotted you somewhere at the regional hospital in Limbe recently, Dr. Fobi, and I know you are very interested in what is happening back home in the healthcare space now. And I'd like to get your thoughts. You were in the regional hospital in Limbe. You might have interacted with some other healthcare providers and sectors in Cameroon. What's your assessment of this situation? And just share your thoughts about what this suspension means to Cameroon.
Well, thank you for asking me. I was in Cameroon for 2 months and a half, and I visited some of the facilities, both private and governmental. and I had a chance to interact with some of the doctors. I'll honestly say I do not know exactly what the effect of this US aid suspension would have, because I cannot quite tell you how much of the help people were getting they came from US aid. But I'm sure that some of the missionary hospitals had some links, but I cannot authoritatively say what it is. I think we just have to wait and see, and probably reach out to what we call the regional directors, both in the Northwest and Southwest province, to see whether this affects them, because they will know better. I would be telling you a lie if I said I knew what the impact is. But Dr. Ngacho, who just spoke, who is in private practice, expressed what I would think I would probably say is my first reaction. I think this is a wake-up call to all of us Cameroonians about taking up our own responsibilities. But I will tell you that things in Cameroon, particularly Northwest and Southwest region, are really desperate from me looking at it when I visited. The doctors are getting poorly paid. There's a disparity between private care and governmental care. The Cameroonians are not happy with the care they get because they figure that the doctors were not donating as much time in their practice at the governmental facilities as they should. And being a doctor, I could empathize with the doctors because of the way they were poorly paid, in terms of how dedicated can they be when you're getting reimbursed so poorly. But again, I need to, I'm going back, and all I'm going to tell you is that I'm going to be able to say more about things like this when I go back and spend more time, because you cannot quite say much, because the restrictions in terms of movement in the country, because of the crisis, makes determination of the effects of things like this difficult to determine. So let me pass this on to next time, and probably relegate to Ted, Ngachu, and those who are on the ground to talk more about this, because they know more than I do.
Thank you very much, Dr. Fobi, and we're really glad that you spent quite this 2 months in Cameroon, and you've really interacted with healthcare professionals. You've seen firsthand some of the challenges, and we really hope that as you continue to invest your time more in Cameroon, you really contribute, because a lot of people respect you as a global leader in this space, and we hope that Cameroon will benefit a lot now that you're spending some time home. In 2021, the African Union states committed allocating 15% of their annual budgets to healthcare sector, a pledge known as the Abuja Declaration, which I misquoted previously. But however, as of 2021, the average government health expenditure among most African countries was approximately 7.4% of their national budget, which is less than half the Abuja target. And notably, only a few countries such as South Africa and Cape Verde have met or exceeded the 15%. And you all know the battle between Donald Trump and South Africa now. Recently, he just stopped any foreign aid to South Africa because of the verbal conflict that is going on between the both presidents. But of course, if South Africa already had 15% of their budget in healthcare, I can see why their president can be bold enough to tell America to keep their America for the Americans. The proportion of government budget dedicated to healthcare varies significantly across the continent. And I think in Cameroon, we still haven't even reached the 7% of our healthcare budget allocated to healthcare. We have Professor Buguma Titanji. I've been reading your post on LinkedIn, and you've been very vocal about, African nations getting this as a wake-up call for them to really, really take responsibility for their healthcare sector. I would like to hand over the opportunity for you to share your thoughts on this suspension and what you think we should be doing as Cameroon.
Hi, thanks for the opportunity to speak and reflect on this. What has happened in the last week or in the last 2 weeks, and we've all been processing the information, I don't think that there is any African government that can say that any of this is coming as a surprise. And I would focus sort of like the comments I'm going to make, particularly pertaining to PEPFAR, which is part of the U.S. aid package that has been supporting the response to the HIV epidemic in Africa for the last 22 years. When PEPFAR was established in 2003 by the then U.S. President George W. Bush, it was established as an emergency fund to respond to what at the time was a crisis in terms of the number of people who could not access antiretroviral therapy on the African continent and the scale to which people were dying. In many countries that were most impacted by HIV at the time, the life expectancy was down to 40. For example, in countries like Uganda, where HIV decimated large swaths of the population. And that program that was established to respond to a particular crisis has gone on to save an estimated 20 million lives and prevented 5.5 million children from being born with HIV. Today, as we speak, there are still 20 million people in sub-Saharan Africa who depend on PEPFAR for their antiretroviral therapy treatment. Sub-Saharan Africa is home to 70% of the people living globally with HIV. I think that it is an absolute travesty that in the 22 years of the existence of PEPFAR, African governments have not been able to step up to the plate to ensure that life-saving medication for people within their own countries is not directly tied to the whims and caprices of a foreign government. And when you go back and you look at the makeup of the US Congress in 2023 and in 2003 and the current makeup of the US Congress, there are almost no remaining Congress people in Congress today who were there when PEPFAR was initially created and authorized. So the people who are making the decisions now every year whether to fund PEPFAR or renew its funding are people who are quite far removed from the crisis that PEPFAR itself was created to address. So again, it's no surprise that they also feel removed from the responsibility of having to keep that process going. But then again, when we take a step back, should we really expect a foreign government to be the one that is stepping up to take responsibility to ensure that medications that are essentially life-saving medications are available to citizens of countries, autonomous countries within the African continent? And I think that that's where the discussion for me should come, is that a lot of people who are suffering right now, the patients who need medications, the people who depend on these services for their HIV care, they're far removed from the levers of power. They have been turned into beggars because there's been an abdication of responsibility. This far out into the HIV epidemic, we now have almost every first-line medication that is available to treat HIV available in generic form. There's very little justification as to why these medications are not being able to be manufactured on a broader scale on the African continent. So while this is a crisis, I think that it is also an opportunity and a call for the leaders of our countries to step up and take this one challenge. I'm not even talking about the Abuja Declaration to increase the percentage of funding for health by 15% in individual countries. Just take the question of HIV. With 70% of the burden, just that challenge to say never again can, at the flip of a switch, the leader of another country turn off supplies for HIV medication to 20 million people on the African continent. And I think that that's really where the reflection should begin. And I'll stop there so that I give other people opportunities to speak as well. Thank you.
Thank you very much. I'll hand it over to Brian to take the next part of the moderation with a series of questions and coordination.
Yeah, thanks a lot, Elvis. And just a quick follow-up question for you, Bogoma. Are you concerned that we might see a resurgence in HIV across the continent, across Africa? Are you concerned that we might see this reversal might lead to a resurgence of not just the gains that we've had in HIV, but also other infectious diseases? And what are some potential outs for us?
Absolutely. I think it goes beyond concern. It is a certainty. We know that antiretroviral therapy is essentially prevention. When you treat people who have HIV, you essentially prevent them from being able to transmit it to other people, because essentially it makes the virus undetectable. So if all of a sudden you have 20 million people who can no longer access HIV treatment because there's no funding for PEPFAR, what that means is that you're going to have a lot more people with detectable virus, and those people can potentially pass on that virus to other people. So it is going to reverse gains that we have made in terms of the numbers of new infections that we are seeing in HIV every year. Additionally, when you think about prevention measures like pre-exposure prophylaxis, when PEPFAR was renewed for an additional year back in 2004 to fund it for one more year, one of the things that they expanded funding for was to expand funding for pre-exposure prophylaxis. And the goal was to scale up the number of people in African countries that had access to pre-exposure prophylaxis, particularly focusing on that age group of young women, adolescent and young women between the ages of 15 to 24, who are currently the most impacted group of people with HIV. It's estimated that 4,000 girls and women in that age group get new HIV infections every week on the African continent. And that pre-exposure prophylaxis access expanded by PEPFAR, the goal was to reach that population and really put a dent in the number of transmissions that we were seeing in that age group. Now, some of the exemptions that have been put out by the State Department regarding how PEPFAR funding can be used stipulates that PrEP can only be dispensed to pregnant or breastfeeding women. Again, meaning that young women between 15 to 24 who are not pregnant or breastfeeding can no longer access pre-exposure prophylaxis, nor can their male partners, who are also potential sources of HIV acquisition and spreading and new infections of HIV. So all of these areas are areas where already the gains that had been made in terms of controlling the HIV epidemic were very tenuous, and we had actually reached a plateau because we were trying to think critically about how best to use the tools we have now to really focus on target populations to continue to move towards the goal of eliminating HIV. And these gains are most certainly going to be reversed if we don't see a restoration of PEPFAR funds. And before I go to kind of like what can we do, I wanted to also emphasize the fact that even if PEPFAR is restored, one thing that people should understand is if USAID in itself is completely gutted, a lot of the logistics that PEPFAR relies on to be able to get medications in country, to be able to operationalize its functionality in the countries where it operates, relies on USAID infrastructure. One of the cuts that has been made, they're downsizing the agency. One of the plan cuts is downsizing from 10,000 to 14,000 employees of USAID down to 240 something, with the allocation for people working in Africa being reduced down to 14 individuals to run USAID operations within Africa. That is nothing. Without the logistical chains, without the operationalization of USAID on the African continent, putting out a statement that says you can still dispense the ART that is available to people who need it is useless, because you need people to actually put into effect those measures. For example, South Africa makes ART. They don't rely on PEPFAR for ART, but they rely on PEPFAR for a lot of the functionality of the HIV treatment centers in terms of paying people who work in these facilities, in terms of providing testing resources in these facilities, and other logistical support. So in speaking with colleagues who are in Uganda, in Kenya, in South Africa, they've had to lay off staff that are dependent on USAID funding. So even if you say dispense the ART, there's no one there to dispense that medication. Clinical trials that were ongoing, they have had to lay off staff on those clinical trials. There's no one there to be able to follow up those patients. Promises that were made to patients in terms of you're participating in this trial, so you're going to have access to testing, access to the trial drug once the trial is completed, etc. Those guarantees can no longer be maintained. And that breach of trust, even if you restore the funding in 90 days, you cannot, on the flip of the switch, get back all of these people who have been fired, get back the clinical trial study participants, and pick up from where you left off. So the damage, a lot of the damage that has been done is potentially irreversible. Now, coming back to what African countries can do immediately, is the key crisis right now is that there are people who would show up at the end of this month to an HIV treatment facility. If you take, for instance, within Cameroon, the Baptist Health Service that relies a lot on US aid funding for the ARTs that are dispensed within that health health system, there are people who are going to show up at the end of the month who will not be able to fill their antiretroviral treatment. That's the immediate need. What can Cameroon government do to make sure that even if we don't have access to ART next month, that doesn't become a problem where by December, some of these people still don't have access to ART? That means that you have to have a situation where this is treated as a crisis. There are 1 million people in Cameroon living with HIV who depend on these medications. How do we procure medications to make sure that they are able to get their treatment? That may mean deblocking funds and directly negotiating with generic manufacturers in India, in South Korea, in other countries where these drugs are manufactured as generics to get medication in country. That takes time, right? Because suppliers already also have contracts with other countries to deliver. So you may be coming into the supply chain queue, not being the first person on the list that they have to deliver to, but them telling you that they might be able to deliver medication to you in 2 months. Those conversations have to start now. I take the example of an announcement that was just made by the Minister of Health in Nigeria in response to the cuts. Is the Nigerian government deblocked 1 billion naira and said that money is going towards strengthening malaria, TB, and HIV responses to try and plug the gap that is being taken away by the loss of US funds. We need to see more African countries do that, at least to prioritize what is the crisis: preventing mother-to-child transmission of HIV, getting drugs to pregnant women who are living with HIV so we don't have more children born with HIV, and then getting treatment to people who already are on ART and are now faced with no longer accessing medications. Now, thinking about PrEP and testing and all of that, when you make the order of prioritization of how things should be done, those things can come later, but these will be things that we will have to start budgeting for. We can no longer afford to outsource key pieces of our health to foreign countries.
Yeah. Dr. Titani, thanks a lot. Dr. Titani wrote a really brilliant piece. I think I've dropped the link in the chat. I'd really encourage you all to subscribe to her Substack channel. Really great source of information, insights on what's going on in global health. So I encourage everyone to subscribe to that Substack to really stay updated. And Dr. Titani, one of the points that you made in that article was this over-reliance of African nations on donors and how it's set of established dependency. Wondering, just one last follow-up question for you is how can this foreign how can we recalibrate the aid we are receiving from these international partners or donors so that it doesn't perpetuate this dependency that we have? Because the context we have in Cameroon in particular, and in many African countries, just the economic and political constraints that's been existing for years. And I'm wondering your thoughts, and you really laid this out brilliantly on your article, but I'm kind of wondering how you think those sort of donations can be recalibrated so that it doesn't establish dependency for our nations to international donors. So what are your thoughts around how we can recalibrate? You mentioned the example of South Africa and Nigeria as well. I'm not really sure how, I mean, South Africa certainly has more resources, economic resources. Nigeria, way more resources for us as well. But wondering if you could expand a little bit on your reflections on that, or what you were thinking when you wrote that particular piece on self-reliance on international donors, but also ensuring that we don't become undermined, or we don't become essentially dependent on this foreign aid in order to self-sustain ourselves.
I think that any aid that is provided, or any plan for aid that is provided, should come with a built-in plan for assuring sustainability. And there should also be a plan for how that aid will be phased out over time. And I think that when you think about a project or kind of a funding mechanism like PEPFAR, again, remember I reiterated the fact that when PEPFAR was created, it was an emergency fund. So there was an emergency, PEPFAR was created, but what was the plan? Were we supposed to stay in emergency for the next 50 to 100 years? And what was the plan for after the emergency? So it's about African countries also stepping up and recognizing that if we want to be taken seriously, if we want to leave the children's table and really have a seat at the adult table, we also have to have a transition plan for every time we accept aid. So if you're coming to my country to give me aid for supporting child immunization, or for supporting malaria treatment, or for supporting HIV treatment, the conversation of receiving that aid and the planning must incorporate how are you going to ensure that when this aid is no longer available in 5 years, that we are able to still continue providing these services to populations that will become reliant on it. And I think that where a lot of the failure happens is that these conversations do not even happen at the genesis of the aid. And that's because a lot of the recipients of aid and the people who are making the decisions to receive aid are not putting at the forefront of these negotiations the people who are likely to lose the most if that aid is abruptly cut off. So if you have a strategy in which you're thinking more about how that aid is meant to serve the population, not as an emergency, but rather over time, then you're going to ensure that there are parts of the funding that you receive that requires that you're able to build a lab where you can do the T-cell count testing and the viral load testing and implement a mechanism where that lab can be self-sustaining without US aid, or if foreign aid is suddenly pulled out. Now, coming back again and using HIV care as an example, it's great that antiretroviral drugs are free of charge through PEPFAR. But again, the expectation has been built in the 1 million people who need ART in Cameroon that they don't need to pay for their medication to get it. Now, it's estimated that the cost of antiretroviral therapy per year through PEPFAR is about $58 per year. If you convert that into CFA, that's about 25,000 CFA that you spend a year on your health. If at the outset, Cameroon's government had said, sure, PEPFAR is giving us support to be able to pay for this ART, but for your own health as an average Cameroonian, you should spend $12,500 a year for this antiretroviral therapy. Invest in your own health as well, so that it's 50-50. The government, PEPFAR is absorbing 50% and you are absorbing 50%. Then you break that dependency a little bit, because then if people were already accustomed to paying something for their ART, if now the government only had to cover 50% of that cost, it will be less heavy than absorbing the 100% cost. So there are mechanisms by which you can think about breaking that dependency, but these conversations had to happen at the negotiation table when the aid is offered. And that can only come from the leadership. And the leadership has to recognize that 50 years, 60 years post-colonialism, you cannot be approaching it as always extended arms, waiting to receive without wanting to take any responsibility for your own development and growth.
Well, Bogoma, thank you so much for your insights. Really, really deeply appreciate it. And probably will come back to you regarding other things, maybe around the NIH restructuring around NIH funding. But I wanted to pass it on to Dr. Ojong. Ojong, I know you're here as well, and not sure if you're still leading the program in the UNICEF program in the DRC, but really wanted to wanted to invite maybe it's some of your reflections on the impact of the World Health Organization's the US withdrawal from the World Health Organizations and the ramifications that might have on health programs, public health programs across the globe. How did you receive that news? And I think we've seen other countries stepping up. I've heard about Argentina and Italy and several other, pledging to withdraw completely from the World Health Organization. So I'm kind of curious around your thoughts on the potential ramifications that might have across the continent. Dr. Ojong.
Hi, Brian. Hi, everyone. Maybe just to indicate from the very start that any opinion I will be sharing is strictly my opinion. Yes, I still work with UNICEF. I am no longer in the DRC. I now work in UNICEF in Mozambique, which is another one of those countries which is really, really dependent on aid, especially for its HIV program, with PEPFAR investing per cycle nothing less than $1 billion. So as someone working with UNICEF, I cannot give any opinion whatsoever organizationally speaking. But I'll maybe make give one or two perspectives, not adding anything, of course, to the brilliant points raised by Dr. Bogoma. The first thing is, I'm just trying to go from Dr. Bogoma, who said 60 years post-independence, our country should be acting different. We should agree that a 60-year-old with cerebral palsy cannot be expected to show any level of potency even at 80, right? Cerebral palsy. And that is the reality of many of our countries. I am at that intersection of seeing not just the evidence or the science behind health systems, but the reality, the bigger picture, right? Fiscal spaces, that's a reality. Prioritization, that is a reality. Competing priorities, there is we can question the will of our leaders to want to bring in a new paradigm, a new way of doing business, a way that basically empowers them to be the main deciders, or empowers the African people to be the main deciders of what happens on their continent. But the truth is, beyond bad God, beyond everything we can criticize on the continent, in many ways, many countries are just not ready yet to take that step. It's worse than what we can think, worse than what we can imagine. Secondly, I not just PEPFAR, but all like global health initiatives have done a marvelous job in improving access for the most vulnerable persons. You know, it's not only HIV, it's HIV, it's malaria, just think about it, tuberculosis. The global health initiative is access to immunization. They have been really, really critical in ensuring access. But what is the net gain for the health systems in these countries? We will not argue that most global health initiatives basically create parallel systems. In many countries, the best data you will have on HIV is PEPFAR data. And there is always discordance between what's PEPFAR data for HIV and what's administrative data at country level. You know, why do we have that? Why can global health initiatives not integrate the health system and strengthen the health system? You know, we can have that discussion. It's not always because the leadership on the ground doesn't want, you know. For me, those are some of the other issues we should look at if we want to understand why the countries basically 30 years after the initiative, 40 years after the initiative are not ready to scale up, are not ready to take over. You know, there is no global health initiative as of now that can prove in any country in Africa that they have come and seamlessly integrated the health system and moved the needle. No, it is parallel systems. Those are the questions we should be talking about, you know. And then, of course, the final point I'll make is, it's unethical, right? It's unethical. You cannot turn off the machine in the resuscitation room. You just cannot turn it off in the name of, I don't know, in the name of what? You just cannot turn it off. We are not ready for this curse. And we just pray that something happens soon. But maybe it's an opportunity for other countries, for other organizations, for other stakeholders to come in there, right, and plug the hole. Maybe we need to move more towards a multipolar situation in global health, and not unipolarity. Ultimately, something needs to be done. Maybe one thing which Africa should take out of this is, and that's where we bring the African CDC agenda, right? We want to produce on ground. We want to do our own logistics. We want to produce locally. We want to define health systems for Africa by Africans, you know, funded by Africa. But maybe it's time to have that discussion. Agree that we might pay a little bit of the price. Agree that there'll be some lives. There'll be lives lost. You know, there'll be many. We'll go back many years. There'll be huge losses in gains that have been acquired by the last 20 years. But for me, the first step now is, can Africa set an agenda of our own instead of complaining about an agenda that is visibly working against her? So those are just some of my perspectives.
Yeah, thanks a lot, Dr. Ojong, and thanks a lot for sharing those reflections. It's really deep-seated thoughts there as well. I also wanted to call on Dr. Pat. Dr. Pat, and I see you're here. Not really trying to put you on the spotlight, but I wondering how you've been processing the recent, from a global health security standpoint, how you've processed the recent changes that are currently occurring in this current, landscape, and how you potentially see this impacting the gains that we've already made in global health in the global south, and the potential ramification. I know this disruptions has been met with a lot, like Dr. Ojong mentioned, has been met with a lot of criticisms and everything, and everyone thinks it's unethical and all that. But kind of curious about how you've been processing this and what the way forward is. Dr. Pat, please.
Thank you. Hi, everyone. It's been a while, and I have to say, my views, what I say today, are my own and does not in any way or shape represent my my affiliation with my other organizations. So, again, thank you to everyone who's intervened so far, and I really like all the points, especially from Boguma. So it is a crisis, I have to say. I have to recognize, first of all, that I have been in projects that have benefited, or led projects that have benefited from PEPFAR, USAID, and I have a lot of my colleagues here in the United States and around the world, in Cameroon, everywhere, that that are in disarray at this moment. Now, coming back to what I see it doing, there's, and Dr. Titanji said it very well. We are stepping back. There's going to be a lot of concerns, and talking about HIV itself, yes, we're going to see, you know, that path to 2030 or whatever else we have set it. With this happening, it's not going to reach. We're not going to get there, right? And especially for the restrictions, when we talk about the key populations, we don't want to see that anymore. We all know here that we have a lot of efforts to do, yes, in the girls, in the young population of girls, but also in the key population. So if those targets are not met in these populations, we are setting ourselves backward. It's going to be HIV, but it's also going to get complicated with other emerging infectious diseases. As you all know, we've been using the platforms that PEPFAR put in place to track other diseases, for surveillance for other diseases, for supply chain, for many other mechanisms. So we are concerned that we see a resurgence or emergence of other diseases and the spread of other diseases around the world because of the lack of resources from PEPFAR or from the aid, but also because of the lack of human resources here in the United States, but also our colleagues in Cameroon and other countries. There's going to be a setback. But what I would like to say is thank you, Boguma, for bringing up the sustainability issue. I have to say, for the past 10 years or so, all implementing partners have been not just encouraged, but there's been thought about putting sustainability plans in all the projects we applied for. Unfortunately, I would say it became an academic exercise, right? We put out these plans, and in country, we have not seen countries seize the opportunity and make sure that those plans are beyond the academic exercise, that those plans are seriously taken into consideration and implemented. And the result is we are here. We are in a situation where so many years down the road, what do we have to show for, right? In terms of our own country. I'm not gonna say anymore, but I will say in any challenge, there's an opportunity. It's gonna be difficult for those crippled governments, like Dr. Ojong said, to turn around and do something right away. Yes, it is a wake-up call, but it's gonna take some time for them to get organized, hopefully, and seize this opportunity and get the right path to independence, the right path to their own, to care for their own populations. The challenge is us sitting here. What do we do? How do we come together as a grassroots movement and do something about it while our governments are getting hopefully organized? Or how do we bring them along? Sometimes it starts with us, right? Sometimes it's here where we start, and hopefully we're going to have another conversation as to how do we come together and do what we can, put some things in place to alleviate the pain of PEPFAR leaving so suddenly. I'll stop for now. Thank you.
Yeah, thanks a lot, Dr. Pat, and thanks a lot for all the work that you do in global health, and deeply appreciate it. I said earlier that we are still sort of recovering from the ramifications or the effect COVID-19 and all the vulnerabilities in that surveillance infrastructures that was exposed. We haven't really recovered from it, and we are still kind of hit with this strong blow. And I'm wondering, I know you mentioned we could talk about this later, but what sort of surveillance infrastructures that do you think, or early warning systems, do you think from a global health security perspective, do you think African nations need to take ownership, need to prioritize in order to prevent, in order to secure our own health? Curious around things around infectious disease. We are currently seeing an outbreak in, the Ebola crisis that's currently happening again and Marburg virus as well, that's currently happening in some African countries, and the response we are seeing there as well. What are some things that, and the funding shifts for sure are disrupting those programs as well, the World Health Organizations and all that on the ground. But I'm curious your thoughts around what priorities our African nations should probably try to strengthen in order to secure our own health and our own future.
Thank you. I'll give you a stab at it, and please, everyone, you can chime in. Someone just mentioned the fact that sometimes even in our countries, even the data, let's say simple HIV PEPFAR data might sometimes runs in parallel. With COVID-19, we saw that even only at the country level, we don't even have the infrastructure to have correct data that can be then used for decision making, even at the district level at times, right? So we need to start from within. We need to start from the very basics, like the Emerging Operations Center, even at the regional level, what kind of data is going up to the EOC, and then from there, from the region to the national level. But now, when we talk about all the emerging infectious diseases we're seeing at the regional level, I don't see, and someone can help me here, I don't see even at the regional level, let's say Central Africa, what do we have from Cameroon to Gabon or Equatorial Guinea to say, hey, we are seeing emergence of X disease, be careful. We don't have that infrastructure, and it's going to be important. The WAHO, through some mechanism have been trying for a long time now to set up a regional response reporting mechanism for some priority diseases. They have a platform. I don't know that at this time, sitting from each one of those countries, in ECOWAS countries, you can access that platform to determine what is coming your way. So all that to say, infrastructure is really lacking within the countries and among neighboring countries. And again, that's somewhere, we start somewhere, right? We start building somewhere. We have strong community health workers from the PEPFAR HIV. We can start building from that, and instead of reinventing the wheel, use and leverage that same mechanism for other infectious diseases and go from there. Thank you.
Thanks a lot, Pat, and thanks again for joining. Dr. Ferdinand, please welcome to the town hall. It's great to see you back again. I know this is probably very dear to your heart. So wanted to maybe invite you as well to maybe some remarks. I know global health is one of your main passions, and this disruptions definitely affects that a lot. So I'm curious what your take has been on these recent changes that we've been seeing. Then I think next, if you have any contributions, anyone else, please just raise your hand and I'll try to do my best to call you on. Dr. Ferdinand, please.
Hi everyone. It's nice to be back, and yes, of course, this is really dear to my heart. Which is why I've had to break my sleep somewhere in the middle to come and attend. I really want to thank Dr. Pat for the points she's made, because they resonate with me quite a bit. I was discussing the same issue with my Indian colleagues yesterday, and I'm just sharing them the perspective from Africa, and they asked me the same question. So what can we do in Africa to start putting things in place? And it is the same thing I mentioned: infrastructure.
we need to start from there. There are no infrastructures that we have. Even to start tracking diseases, we need better laboratories that we can we can start diagnosing diseases and all this. We really need to start relying on ourselves more than for fundings that are coming from abroad. Because to me, this situation, I think it should be more than an eye-opener for us than any other thing else. It should be a situation where we can say, I think that we need to start learning how to fish and stop depending on the fish that is coming from abroad. We need to start going to the ocean ourselves and pulling out the fish to feed our own villages and our own people. Because in the long run, those fundings, PEPFAR, USAID that came, what concretely can you show that they have achieved in Cameroon, for example? Let's say they've been there for 30 years. What can you show that they have achieved? What sustainable systems have they put down in place that you can see? What they have done is remarkable, but where is the sustainability? That's what we cannot see. But here in the US, if they want to build things, they build these huge structures, create incredible systems that will last for centuries when they want to do something like track a particular disease. But the same ideology is not being applied in Africa. It is only just temporary things that are being done. But then these humongous figures are being reported in these papers. Oh, 30 billion has been spent, 50 billion has been spent, where we cannot see any structure that shows you've spent 50 billion or 30 billion. We cannot see it. But if somebody says in the US that I've spent 50 billion, they will show you a building, they will show you a laboratory, they will show you top of the range technology that has been put down in place. Show me one in Africa or in Cameroon. Even in universities, build better universities or even health infrastructure. So my take is, as everybody else has said, we need to, our own government, call them to start putting down our own structures. Thank you.
Yeah, thanks a lot, Dr. Mokumba. I wanted to ask you about what you meant by specific infrastructures that you think would be the most sustainable for making Africa most self-sufficient. What if you had the funding, or if countries reached out to you specifically, what do you see as the most needed investment in infrastructure that would make the country or the continent most self-sufficient for the future?
That is an amazing question. Thank you. So, for example, and these are my views. If you want to come and support the HIV program in Cameroon, rather than find pathways to be providing ARVs in Cameroon and all that, why, if I got the funding, what I would want to construct is a laboratory where we can do viral loads quicker and even better point of care, things like that. I would also look for sustainable ways. And can we get a place where these ARVs can even be manufactured, even in Africa? Can we get the patent? These are sustainable things that can be done rather than still depending on this medication coming from India. What is wrong? Can African scientists not take that patent and be able to make ARVs? So those should, to me, would be sustainable ideas towards things that we can achieve. Yeah.
Yeah, thanks a lot. Thanks a lot, Dr. Fezin. I really appreciate the feedback. I don't know if Dr. Allen's his hand had been up for a while. Dr. Allen, please.
Okay, thank you, Brian, for the opportunity to speak. I don't know, can you hear me?
Yes.
Okay, it's difficult to add my word to the very brilliant speakers who have spoken before me, because I think they kind of touched a good number of the points which I wanted to make, but I would just maybe give my 1 cent on what I think about the suspension of the foreign aid, especially in Cameroon and on a larger scale in Africa. It's really unfortunate that it took someone, Donald Trump, to make us realize our dependence. And it is a shame that for more than 5 decades, we have to literally outsource the public health of populations in Africa to international donors. This has really become a routine for the governments, where they have been accustomed to receiving funds, and they think that, you know, the pipe or the tap would keep flowing forever. If for anything, beyond my sympathy for what is happening, I really hope that our governments would implement policies that are going to be sustainable long term. And talking about that, my opinion about this is, scientists that we are and healthcare providers that we are, we can organize these meetings and rant all we want. But I think that the real solution to this problem is going to be a political solution. It's going to be a drastic change and a drastic shift to the way our governments look at and target health policy. I think it boils down to policy, because if you're going to talk about what Dr. Buguma and Dr. Titanji and all the other players have mentioned, it boils down to the fact that we are not prepared. We as scientists, I think in the last, from my research of recent, these calls have been made by so many people, not only in Cameroon, but across Africa. And there has not been a lot of will to spend more on healthcare. They have prioritized other things, which in my opinion are less important than public health. The economy is obviously very important, but then again, if you have a sick population, then your economy is bound to take the hit. And so the one way I think this can be solved is, I'm happy that Dr. Stanji has just shared a letter, which I think it's too late. It should have come maybe a week or two before, from the Minister of Health, talking about the analysis, but I guess he was drawing his analysis of the situation. We are going to be impacted in a big way, and my wish is that the policymakers should listen more to the experts in the field, to the healthcare practitioners, and we should stop outsourcing our healthcare. There are many ways we can do it. We can start by negotiating for cheaper drugs, making drugs more accessible, or what we call in French import substitution, which is one of the things where the Ministry of Health has been trying to do, to replace imported medication with cheaper, maybe usually generic medications, and it cuts across the board. The focus today is only on HIV, but we have things like malaria, we have things like cardiovascular diseases, we have non-communicable diseases, we have the increase in cancers. All of those need to be taken into consideration. And I think it needs a real political will. And if anything, we should be educating people about the role of our leaders, our political leaders, in changing the healthcare landscape. The politicians are the ones that have the final say. They're the ones to have negotiations with international partners in terms of procurement of medication, in terms of maybe building infrastructure to have local manufacture and sustainability in the long term. And people should be made to understand this. And as long as the politicians don't listen, we would rant and rant and nothing would change. So if there is a way forward, we should be more about educating the population about the role of the politicians changing the healthcare policy and how that affects their health. We cannot 60 years later continue to depend and outsource our health as a country and as a continent. And every day we're crying about colonialism, whereas we are always there ready to beg and receive funds and borrow money. So we need to start maybe by making the population understand what is going on, because most people before the suspension of this aid did not even know that this was foreign aid. Most of the time, our governments would say, hey, we are the ones making this medication available for you. It is through the partnership of the government and this person. They never tell people that this is literally backed medication. Let us call it the way it is. This is backed medication, and we are at the mercy of foreign donors who can stop this, as we have seen at any moment of in time. So it's important for people to understand the role of the government, the role of politics, the role of politicians in their healthcare, and how it affects all aspects of their life. Thanks.
Dr. Allen, thanks a lot for those reflections. Really deep reflections there. Really appreciate it as well. I want to call back Dr. Bogoma-Titanji, please.
Yes, I just wanted to add to some of what has already been said, just pointing out in terms of one of the questions that came up was what concretely in terms of infrastructure has been left behind by programs like PEPFAR. I just wanted to say, although they might not be a structure or a hospital, one of the things that PEPFAR really revolutionized was every country that received PEPFAR funding is capable of conducting viral load testing and CD4 T cell count measurements. That equipment is there, and actually a lot of that equipment was leveraged to do COVID testing and respond to the COVID pandemic during the pandemic. Additionally, almost virtually every HIV treatment facility that's funded by PEPFAR also has Cepheid testing for TB, which is a platform that is currently being leveraged to respond to the Mpox outbreak that's happening in countries across Africa. So there are some of these pieces of infrastructure and equipment that is a legacy of PEPFAR. That was the first point I wanted to make. They could have done more, but there's certainly a legacy that has transformed health surveillance well beyond HIV on the continent. The second point I wanted to make is that in terms of concretely, we keep talking about how to break dependency, and I heard a lot of people mention Africa CDC as being one of the up-and-coming public health organizations within the continent that is trying to play that role of being like the interlocutor between countries and really coordinate public health responses. It goes back to ownership. Some people on the call may already know this, but I'm sure many of you are not aware that Africa CDC is heavily funded by America CDC, USAID, and PEPFAR funding. Additionally, by the European Union, the World Bank, the Bill and Melinda Gates Foundation, the Global Fund, the Wellcome Trust, and China CDC. These are all people who fund Africa CDC. Of course, the African Union provides a portion of the funding for Africa CDC, but the bulk of funding that keeps this African organization running is still, again, coming from external funders. So it all comes back to, as a continent, is Africa ready to take ownership where its health is concerned? One thing that we must also kind of understand, and going back to educating the public about how funding works, there's no free lunch. When a funder gives you money, they are getting something in return. Take, for example, HIV and the progress that has been done in terms of antiretroviral drug development, pre-exposure prophylaxis, HIV testing, HIV vaccine studies, the number of HIV clinical trials that have driven the field forward, which have been conducted on African bodies, is significant. So PEPFAR gives that money, funds that research, but the information that is generated often also propels treatment and cures for countries around the world. And I think that that is already a key piece of an argument that our leaders can leverage and say, well, if you're coming into my country with this so-called funding to support me, you're getting XYZ in return. So there has to be a lasting legacy of what you leave here. It can't just be a one-way transaction. And in order to do that, you have to also be willing to know that if you put a clause in for US funding or Chinese funding or European funding, that the funders may be able to walk away from the table and be like, well, if you're giving conditions to us giving you funds, then we're not going to fund that. And the government of Cameroon should not also abdicate and say, well, if you don't fund that, we're not funding it either. Because ultimately, the goal is to better your people. The goal is to strengthen your healthcare systems. So you have to be taken seriously. You have to be able to step up. The final piece I was going to make is that although the bulk of HIV medications in Africa are still coming from generic manufacturers in India, Uganda, Kenya, and South Africa are locally producing all their ARTs. So there are countries that have been able to move forward and generate generic drugs. Other things that African countries can do is try to figure out how does the African Union then coordinate with these countries to leverage that and scale up production within the continent to plug holes that are being opened up by the pulling out of funding. So I just wanted to kind of add these points to bolster the many people who have already made really brilliant points and to also provide some clarification as we continue to have these conversations.
Thanks a lot, Dr. Buguma. Please, Elvis.
Yeah, just really adding to what Dr. Buguma just said, and also what Ferdinand mentioned. I think we are not the only ones that are hurt by this decision. The U.S. Agency for International Development, USAID, allocates a significant portion of its procurement budget to U.S.-based companies. So they are bleeding as well. For instance, Chemonics International is a private for-profit firm headquarters in Washington, D.C. It has been the major recipient of USAID contract with over $17 billion from 2008 to 2024. These were not Cameroon companies. In fiscal year 2025, it's projected that about 190 contract opportunities valued at 27.7 billion will be spent, and most of those who benefit from these contracts are US-based companies. So it is important for us to know that as they bring the money, their companies get it back by supplying these commodities to Africa. So they are getting something in return. If you even go in terms of employment, over 10,000 workers are employed globally by USAID. And some of these workers are American citizens who work in overseas, and they are earning very high wages working overseas with their children schooling in Africa. So this decision also affects Americans as well, both American businesses and American families. So it's not just Africa. And I'm just really trying to say that we should look at this also like there is no free lunch, right? We have to know that we can build our own companies. We can set up our own manufacturing and compete for the U.S. contracts when they are launched. If you have a company that is manufacturing antiretroviral drug in South Africa, and there is a bid to procure antiretroviral drug to supply in Zambia, will PEPFAR funds be used to buy the antiretroviral drug from the South African company? Literally, no. USAID has been really criticized for the lack of transparency in a lot of their contracting activities. So I think there are a lot of these issues that we should know that are also intertwined with this suspension of USAID fund. And don't be surprised, some of those who will be fighting very hard for it to be reinstated will not be even African presidents, will be some of these companies. Thank you.
Yeah, thanks a lot, Elvis. Dr. Kitty Martin, please.
First go on video and then unmute myself. Hi everyone, it's absolute pleasure to be here. I was wondering or worried a few weeks ago and I didn't see Mona's email, asking me to register for the next session. Then I remember that, hey, it's going to be monthly and not bi-monthly as we've become accustomed to having it. But when I saw the topic, I was like, absolutely, whatever it is that I'm doing, I have to come on this call because I knew that this was going to be the quality of conversation that we're going to have. Access to healthcare is something that I've always been very passionate about. I had the privilege and burden, to handle a small IPEC of just about 100 patients. And I know the issues I had when there were shortages in these medications. And most times it was not even a definite, there's no medication. They'll say, okay, instead of 3 months, we'll give you a month. And I know how uneasy my patients were every time I gave them a month supply as opposed to the 90-day supply that they were used to. So we are in a serious moment in terms of public health in Cameroon. But another thing that I was also unfortunate enough, but also fortunate enough to experience was the fire that happened in Sonora about, it's incredible to think that's about 6 years ago now. What happened is that Sonora was a company that was the sole or the monopoly in terms of oil refining in Cameroon and supplying the entire country with refined petroleum products as well as neighboring countries. So when the fire happened, pretty much our supply was cut off. So a similar thing is happening now. This time it's with drugs. And my recommendations or my thoughts are, along the lines of the things that I not only witnessed, but I was a part of, contributing to how to that response. I'll call it the emergency response is what we called it. Just like petroleum products, these patients need the ARVs to live. Right now, I've been thinking since I heard about this thing, and when I was in Cameroon, working in Cameroon, preparing these drugs for my patients, I had a hard time getting drugs from outside of the PEPFAR program. I don't know if these drugs are available in Cameroon. Professor Theodore can probably shed some light on that, whether he has these drugs in his facility and patients can just, go into the pharmacy and buy this ARVs. In my experience, and my patients were insured, 100% insured, I could not get the medications because they were not there. So I don't know what the procurement chains or the logistics involved in getting these drugs to Cameroon are. In Cameroon, we need them. They are not going to come from Zambia. They're going to come from India because that's where they've always come from. So it's just the payer that's going to change, but we need them. But then in addition to that, because the program is no longer buying those drugs, it's the same supplier, yes, but the buyer is different. So we need, just like we did in the case of Sonora, where you have to know who your importers are, because we know how we are and how our brothers are on the continent. Now we're taking the drugs from India, and we know who is supplying the drugs that are coming through an accredited supplier. None of us will be surprised to know that in 3 months' time you have counterfeit ARVs on the market. They're going to have the labels from these same companies, but they are going to come from God knows who, in terms of the buyers. So we need to, excuse me, just like it was the case with crude oil and finished petroleum products, we need to monitor the supply so that we know the economic operators that are importing these medications, so that we don't get fake ARVs, because the only thing that's worse than no ARVs is fake ARVs. So we absolutely need to know who is going to be bringing them in, because the government, unfortunately, our government is in a very tight financial situation that they may not be able to afford these medications to all the patients. So they may leave it up to economic operators to do it. And then ARVs will go from 0 to 10,000 a month. It doesn't really matter. The economic operators will make the numbers work. That's what they are good at. They'll make the numbers work. But as a country, we need to know who is bringing these drugs in and ensure that the drugs are coming in are of reputable quality, and we are sure that the patients are getting the care that they need. Now, down the line, there are companies around the continent that can manufacture these medications. But today we're talking about Africa Free Trade Zone, and it's about the ease of mobility of goods and people. We started with goods. There are a number of countries now where you can take goods in without having to pay customs duties. That's good. A number of countries are beginning to sign agreements with each other to say that their citizens can go into other countries visa-free. I was interested to see Kenya announce that. I remember a good number of years ago, I tried to go to Kenya and I couldn't get a visa at the airport, just like all the other countries were getting visas, spend the night and had to go back to Cameroon. But anyway, what I'm saying is, as we're going down the lines of making trade possible, moving goods across, moving people across, this is an opportunity for us to talk about the regulatory framework in Africa. Because, as I mentioned in the chat, that it's easier to get a drug that is FDA cleared into an African country than it is to get a drug that is cleared by another African country into another one. So this is an opportunity for Africa as a whole to say that, yes, there are companies that produce these drugs on the continent, but why is it easier to get Indian drugs into Cameroon than it is to get Zambian drugs or Kenyan drugs and the like? So we are in a unique predicament. We are also, sufficiently educated to be poised such that we can use our voices, in the different hallways and corridors where we are being listened to push some of these things, Let's talk to the people of influence that we know professionally, individually and collectively as a group, Cameroon Town Hall, and let's make them understand that the fact that it is is easier to do business and to move things from Europe and the developed world to Africa, as opposed to just moving around Africa, is an opportunity for us to just make things better in the continent. That's it from me. Thank you very much.
Thanks a lot, Ekiti. I completely agree with you. We definitely have to change our drug regulatory framework in the continent. So thanks a lot for sharing that. I don't know if there's anyone here who can speak also about the potential, how AI in general, I haven't heard anyone talk about it. And I know Africa as a continent is significantly behind. Lots of developed countries are taking the lead. And I'm wondering if there are any potential ways in which building a digital infrastructure, AI infrastructure for the continent can really help to at least help with some of the challenges that we have, whether it's drug discovery, whether it's improving our surveillance mechanisms or surveillance systems and things like that, and how really AI can really help in public health or in global health. Really love to welcome that. But over to Dr. Pat, please.
Sure, I'm going to be brief. It's not the AI response, but I just want to say, I was thinking, how do we dissociate this aid from diplomacy, from politics? Probably not, right? Maybe but to be transparent, maybe not call it aid and call it somewhere. But I just also think when we go to a negotiating table, all parties come to protect some of their national interests, and our governments should do the same. And when they go at that table as grown-ups, like Bugumo said, we are intentional in knowing exactly what we want to get out of it and how we're going to use it for our populations. So it's not realistic to think that when someone is going to bring something and for a transaction that they're not going to gain anything out of it. But most important is for us to determine what we get out of it, how we're going to stretch it, how we're going to use it, and what terms we put to the table. That's all I'm going to say. Thank you.
Really agree. Thanks a lot, Dr. Pat. Really appreciate it. Samuel Ojong.
Thanks a lot, Brian, for giving me the floor. And thanks to everyone for the really brilliant opinion shared. I'll make a very controversial statement about digital. I mean, I believe that in digital, there's a lot of opportunity to answer many questions for health on the continent, right? Including in HIV. Digital space is one of those spaces I will classify in the transformation agenda, right? Thrive and transform. So beyond survival, it's important that our communities thrive and that they are key players in their own transformation and their own growth. However, I am sometimes of the opinion that we are too fast to follow the next agenda, which is the reality in other contexts. Like we're trying to answer transform questions when we are yet to click the boxes or to tick the boxes of mere survival. And when we start answering everything that is linked to the paper withdrawal, to funding, to donor agendas, blah, 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 I'm excited to see us raise ethos. I mean, there's authoritative speakers, Dr. Bogoma, Dr. Pat, when they talk, they know these things. And so they have authority to talk about these things. We raise the pathos side of the argument, you know, the emotions, everything that we're going to lose and everything that's going to happen because funding is pulled out now. And then we get into logos, which is the evidence that shows, like everything about the evidence, including now the part you're trying to address, which is how can digital be part of the answer, be part of the solution in all of that logos dimension? And I'm afraid there is one thing we are not touching, and I'm just throwing it there. Ultimately, science and evidence might find all the solutions, but politics gets to decide who takes the pill. You know, the decision from the US government is neither ethos, pathos, or logos. It's politics. It's politics. And once we say it's politics, the question I want to ask is, how much is health a priority on the continent? How much is health a priority in the countries that need it the most, where people are still just begging to survive? And yet, I'm not talking about political prioritization by governments. I'm talking about how much do the people, how much does the common man rate health amongst his priorities? Because I think one way forward also, rather than thinking that governments, African governments will now make the decision to be autonomous, is for African people to make a firm request. In my opinion, today, anybody who wants to lead an African country who's not putting health on the top of his political agenda is not fit to rule on this continent. So how much are the people on the continent saying health is a condition sine qua non, you know, to actually acceding to leadership positions on this continent, because that is where we want solutions. So I felt that I would throw that out there and just keep on listening to the answers, including how digital can be the answer going forward. Thank you.
Yeah, thanks a lot. Thanks a lot, Dr. Ojong. Really appreciate your feedback there as well. I want to call on Dr. Professor Joshua Tambe from FHS, and I also want Jude. I see you're here as well. I saw a really great article you wrote, I think yesterday or 2 days ago, which talked a little bit about this. So I'd like to invite you to maybe share some few words on that as well. Please, Dr. Joshua. Joshua Tambe, are you with us? Okay. Jude, are you able to speak? Okay, I think I just want to just go back to the Dr. Ojong. Probably want to circle back on what you talked about digital infrastructure. I really I guess is curious about what sort of deficiencies or deficits we currently have in terms of my sense is my greatest fear really has been this notion that these recent advances that we see, particularly in AI, is potentially going to create a wall of, you know, two walls, a wall of people who have and a wall of have-nots, and those who have will potentially be developing and controlling the AI, and then another group of countries that are reliant on those technologies. And I'm wondering what, in order to prevent us being dependent, because I really haven't seen any particular models or AI systems that have been developed in the continent that is really robust and independent of the models from the United States or from other countries. So I'm really curious what sort of investments you see would yield the most benefit in terms of securing our global health future in the continent. Dr. Ojong, please.
I mean, that's a very, very interesting question, right? Very, very interesting question. Digital is clearly going to bring wins. No one's arguing that. But let me ask a very simple question. How much of digital technology is Africa producing today, and at what scale? How much of the digital systems that seem to work or produce any sort of result on the continent are local? How many governments are willing to support local solutions? I give an example. One of the most prevalent routine data systems on the continent is the DHIS2. Where is it lodged? Basically, we'll say all the data we are routinely generating in the healthcare system in Africa is not even lodged in Africa. Number two, it's lodged wherever it's lodged in Europe. Someone gets to pay for it to be lodged there. How many governments are paying out of government pocket for their DHIS2 systems to be lodged in Oslo? It's the Global Fund paying, it's Gavi, it's the same global health initiatives, right? So the third thing is, when you talk about digital, then you bring in other components. Okay, if we're not producing, then we're going to buy. So ultimately, we're going to be dependent. And because it's not a priority for our governments, where it's more important today to get malaria treatment in country than to buy a phone and install an app and put in the hand of a community health worker. What you're saying is we will still turn probably to a donor to cover that gap, further creating the dependency. Even when the phones are given, or even when this technology is put at disposal of the healthcare workers, is the reality for a healthcare worker in Yaoundé the same as for a healthcare worker in Mundemba who can spend 6 days on 7 without light, without energy? How does he access internet? Who pays for that? Is there even internet services in the right quality and the right bandwidth to drive these data systems? So ultimately, that's why I said, for me, there is no quick fix. While it's important that in the immediate aftermath, we put in place a series of contained measures, it's critical. I do not think the way forward is for us to look for any magic bullet. We have to accept that we are 60 years late and start the difficult task of building one block, 2, 3, like the full blocks together, and say where we'll be 5 years from now, where we'll be 10 years from now, where we'll be 15 years from now, including for digital solutions. So that's just my take on it.
Thanks a lot, Dr. Ojong. Dr. Pat, please.
Just to build on what Dr. Ojong just said, I'm thinking leapfrog. You know that, Ryan, more than I do. We have a lot of data coming out of the continent for genomic surveillance. We still don't have bioinformaticians to analyze those data. How do we put that together with the gaps in the digital health? And it is possible. We leapfrog, right? We learn from our mistakes, or we learn from our past actions. We have bright fellows on the ground, Polytech and other engineers there. How often do we put our engineers' brain to solve our health problems? Maybe it's time to do it. Thank you.
Yeah, I agree. Dr. Kenji, any thoughts on what Dr. Pat just mentioned? Dr. Kenji, I know you work in the laboratory space as well, and very in tune with bioinformatic capacity and in the continent as well. Dr. Kenji, please. Okay. Maybe we'll get back to Dr. Kenji later.
Sorry, I was trying to unmute myself. Yeah, it's
Okay.
probably a little noisy where I am. Yeah, I think Dr. Pat raised a very pertinent question, a very pertinent issue regarding genomic surveillance. Yeah, we have the sequencers, the laboratory scientists are able to do the weight bench, but then the challenge really comes in terms of bioinformatics. And I think I've been opportune to conduct several trainings in Africa. I think one of the drawbacks of most of those trainings is that you want to train the laboratory scientists to be both a scientist on the bench and a bioinformatics person at the same time and a procurement person at the same time. Come on, that's just one person. There's no way that you can be efficient. right? And I think it is high time we start seeing how we can diversify, some of these skills and start including other people to be able to take up on this. It will be easier for me to train maybe a computer scientist as a bioinformatics person, right? To be able to do that data, for them to be able to write codes, right? It was still like when we're doing this training, right? We are still using like the pipeline from CDC. And with all respect to CDC, it was not really the best when you want to look at intuitive pipeline. So is it like there's nobody in Africa that can build a pipeline that is able to analyze SARS-CoV-2 data, right? So these are things that, we really have to rethink. And again, the way things have gone lately with the new administration, nobody prayed for it, but I think it's just a wake-up call for us to be able to, learn how to do things ourselves. We don't need to rely on CDC or some other external organization for them to write us codes to be able to come out with our own bioinformatics pipelines. At times when I'm looking at sequences in GSAID, you see that the sample was probably processed in, I just call maybe Uganda, for example, but the analysis is done in Central Pasteur in France. Like, seriously, how can you be processing the sample? Then you have to send out all your sequences to be analyzed out of your country, which those are things that people in those countries can actually be trained to be able to do those analysis. So, as my big sister Pat said, we have all these engineers that are graduating. We have all these computer scientists from UB, which, they can do this. And I think that's where education and mentorship plays a big role. Because most often somebody that is doing computer science in Boya only knows that, hey, all I can do is probably what is computer based, what my professor have told me. They don't know that you can still diversify, to do things like writing bioinformatics code, doing all the sequencing analysis. That's all that I would like to share from that. And again, just, sharing my thoughts with the funding cut, again, is really affecting a lot of things, even at the global level, even with WHO, is highly hit. Unfortunately, a lot of things I can't say, but it's really having a devastating consequences, which still goes to that when you access your REITs, when you're over dependent on one particular person for money, that's where the problem comes. Even at work, we always say try to have several streams of income, just so that if you get fired tomorrow, it's not as if you'll be walking in the street and not having a place to stay. I think it's the same thing too when it comes to funding. I think over time, the world and a lot of other countries have just depended on US, not knowing that one day maybe it can go away. And unfortunately, this is what has happened. So thanks.
Dr. Kenji, thanks a lot for echoing your thoughts on this. Really, I really appreciate this. As we are rounding up, I think we just have a few more minutes to go. I want to call on Dr. Bogomati Tanji and then on our chair, Dr. Monofoma, before we close. Dr. Bogoma, please.
Yeah, I just wanted to add one final comment with regards to the great conversation that has happened around digital technology and building that infrastructure. One thing that Africa doesn't lack is a talent pool. And there are extremely, incredibly talented African scientists spread all over the world. What Africa lacks is investment in science and research to allow those scientists to be able to do work. If I had the research support that would enable me to set up a virology lab in Cameroon and do the kind of virology and science that I'm able to do outside of the country, I and many others would not be looking for greener pastures to be able to achieve our full potential. So while there are digital technologies upcoming, there's AI, and there are a lot of things that we could harness to improve the way things are done on the African continent. So far as our governments and our leaders don't invest in research, don't invest in the health sector, and don't utilize all these incredible African brains that are out there, not only in the diaspora, but even within the African continent, and cannot achieve their full potential because of lack of support, then the conversations that we are having will just be one vicious cycle of speaking around the topic. It all comes down to ownership. And this will be the defining moment that would really be a test to see how ready our leaders are to finally step up to the plate and stare reality in its face and decide to work together and invest in their own people. And all I can say is that I'm glad we had this conversation, but time will tell if this is actually that pivotal moment that finally changes the course of the continent. Thank you.
Thank you so much, Dr. Titanji. Really appreciate you being here, and thanks again for sharing. I really encourage everyone to subscribe to Dr. Titanji's Substack. Really great insights coming from there. Dr. Pat, before we close, Dr. Pat, and then I will call on Dr. Monofoma.
Sure. So sorry. So just a positive note, and everything Dr. Titanji said, just like usual, beautiful. As China said, given the circumstances we are facing now, we in the chat here, we've been talking about grassroots movement, trying to prioritize what we do first. And I say, well, we have computer scientists, we have epidemiologists, we have medical doctors. So getting our brains together on the ground and finding a way to use all the data we have generated and AI to kind of predict where trouble is going to hit first. And then we use that for prioritization. It's a great project for a person. Thank you.
Thanks a lot. Thanks a lot, Dr. Pat. And just want to maybe close to Dr. Mono. I know this is a subject that is extremely, extremely dear in your heart, and we've had very lots of debates on this topic. But Dr. Mono, please, your thoughts on the trajectory of on what this means, what these recent changes in has meant to you personally, and what it means for the future of healthcare in the continent. Dr. Mono, please.
Well, thank you. I see Prof's mouth of his hand is up. If you want to, no, it's fine. Yeah.
Sure.
Okay.
Sure, Prof.
Yeah, just want to thank all the discussions. Very interesting topic, very informative, but very sad. What I'm saying is what I have been thinking about for a long time. We Cameroonians, we Africans have to wake up. And I think Mr. Trump is the Judas. Because without Judas, those who believe in religion, Christ would not have died. And if he didn't die, then we would not be saved. This is a wake-up call. Medicine is a very small part of it. HIV is a very small part of it. The whole economic structure of our country has been built on dependence. And our leaders have been trained to be dependent. Those who go back are those who are going back for dependency. That is what I noticed when I went home. The young people who want to do something, get out. Those who want to be dependent on handouts, stay in the country. And so we are suffering from that mental state of dependency. And this is a wake-up call. And it is up to us, doctors, scientists, to let some of our colleagues in the government know that it is time for them to stop being dependent. Because what Trump has started is just the beginning. You know, many of us don't want to look at it politically, but it's very clear to me that as we start kicking out the French military and the American bases out of Africa, they're going to bring us to our knees to beg them to come back. But let's be informed. So when they make us go on our knees, we don't come back begging for dependency again. That's all I can say. But thank you for a very informative meeting. but this is just a small opening to the rest of what we in Africa are going to face. Food, subsidies. We don't encourage our own production of food, not to talk about medications. I mean, medications are so high, so low on the priority list. Cameroonians are not encouraged to produce their own stuff. They talk about it, but it's cheaper to buy rice coming out of Cameroon or powder than to produce it. And that's because those in the position of power are dependent on those supplying it. They benefit from it, and they don't see a way of making us become self-dependent. But again, doctors have always been in the forefront of change, and I hope this discussion here, with all the enlightened minds, might force some of our leaders to start taking a second look. Again, thank you for a nice discussion. It's very enlightening. Thank you.
Yeah, thank you, Prof. And you've said a lot of things that I really wanted to say. So, Brian, thanks for this opportunity. And you know where I sit on this topic. I sit in the middle. This is where I sit in the middle, the fence. The reason is what happens to you is important, always, but the way you react and what you do about what happens to you is what is more important, really, because we're going to test the character of those who are dependent on these programs. What do they do after this has been taken away from them? Are we going to create African solutions for African problems? Or are we going to go back and parachute American solutions or French solutions for African problems? No one has ever developed on aid. No one. So aid itself, it's a power struggle and a soft way of making people rely on you. And I think America is making a big mistake, but that's its own geopolitical interaction. That's not really part of what Africa is. I think this is an opportunity for Africa to create solutions for its problems. We need to start investing where the areas where we think are going to help our future generations survive. I don't know exactly how this is going to be sustainable. In the US courts, the good thing about it, we should ask ourselves, if this happened to Africa, or if this was an African leader, would he succeed in doing what he's doing? I think here the courts are already blocking a lot of these decisions, showing you that there is kind of some separation of power which does not exist in Africa and in most African countries. So I will really want us to reflect on some of the decisions that have been made by the same African leaders. Are we going to invest more than 15% of our GDP on health? Are we going to now start looking at our health as a priority? Are we going to rely on our diaspora that we have trained and get them back to invest home and provide an environment? As Boguma said, if she was able to open a virology lab in Cameroon, I don't know exactly how many people even called her or reached out to her when there was a crisis in Cameroon. But a lot of people don't know she was advising a lot of big organizations. These are all things that we don't even cherish our own. We don't have a way of recognizing talent. We have a way of blocking talent. So I'm just calling out on the leaders, getting everyone engaged into, this is a big political problem, it's not even a health problem. If you want to solve it as a health problem, you're mistaken. And being human is being political. We cannot survive without being political going forward. It's a call, it's a wake-up call for all Africans to reflect. It's a wake-up call for us to start being independent. You asked a question about AI. I'm a believer of AI, and I'm going to give you, I reflect about things I learned in school every day. Why did I do market gardening in California when I was in school? Why was I taught maybe shipbuilding in Sweden? Why there were shipyards in Douala? Why was I taught industrialization in Detroit or all of those things? It becomes a problem in our curriculum and how we are trained. Even the use of AI going forward. But I think strongly, I'm a believer that AI is a big disruptor. If Africa embraces it early, trains the kids early and make them try to use it to their advantage to solve African problems, we have something in our hands, but that could be my own reflection. I do understand we have other problems, which in the Maslow scale of preference, they are basic, that we need to start dealing with, but we can bridge the gap by embracing technology that can change the world. So, Brian, that's my reflection about this. And I hope we have more sessions like this where we can just talk and reflect. And I want to thank everyone who came here, all the brilliant minds. I've just been listening and learning from you all. And I think we'll see you guys in a month. And over to the moderators.
Great. It's been a great session. We've really heard from really brilliant speakers. Thank all of you for being part of this session. We have all agreed that the withdrawal of the U.S. aid funding presents a significant challenge to Cameroon's, particularly the healthcare, humanitarian aid, and economic development sector. And that to mitigate its impact, the government must adopt strategic measures to ensure continuity in essential services and long-term sustainability. And this will constitute Cameroon, being able to invest in domestic healthcare and social programs by, using other budgetary allocations and to strengthen the public-private partnerships that can attract investment and reduce dependence on external aid. We also think there should be the possibilities for government to seek other alternative sources of funding and also building strong collaborations with other regional agencies like ECOWAS and the African Union. Strengthening the healthcare and social system is important. Cameroon should prioritize the health sector resilience by supporting local manufacturing of pharmaceuticals and essential medical supplies and expanding community health programs like we heard from Dr. Pad. We should also think about enhancing efficiency and transparency, reducing corruption, and making sure that as we continue to look for alternative ways to get antiretroviral medication in the country, that quacks should not seize the opportunity to import fake medications that will harm our patients. So we have to strengthen governance structures to ensure that resources are effectively utilized, and also, of course, leverage innovation and technology by investing in digital health solutions such as telemedicine and mobile health platforms to expand access to healthcare in underserved parts of the country. And it's been a really great session. And I would want to end by the quote from Professor Fobi by saying that stop being dependent, because what Trump has done is just the beginning. Thank you all, ladies and gentlemen, for being part of this session, and we hope to see you in a month's time for another session of the Cameroon Town Hall for Healthcare Professionals. And as usual, we're going to host this on our YouTube channel and make it available to you so you can share with those who were not opportune to attend this session. Thank you for all the co-moderators, Dr. Brian Tegomo, Dr. Kate, and Dr. Math for always being there to co-moderate with me, and hope to see you next week for another session of the Town Hall. Bye-bye.